Hello everyone, welcome to my channel. Today we are going to be looking at anatomy of the pericardium. The pericardium. So by the end of this video, you'll be able to differentiate the fibrous pericardium from the serous pericardium, including their layers and functions. You'll be able to locate and describe the two critical pericardial sinuses, that's the transverse and the oblique sinus, and their surgical significance or relevance. You'll be able to trace the arterial supply, venous drainage, and innervation of the pericardium. Explain the basis of cardiac tamponade, pericarditis, and constrictive pericarditis using anatomical principles. You'll be able to apply surface anatomy to the safe performance of pericardiocentesis. So let's get into the video. Now, what is the pericardium? The pericardium is a fibroserous sac. A sac, fibrous and a serous. That means it has a fibrous part and it has a serous part that encloses the heart and the roots of the great vessels. Take note of that. It encloses the heart and the roots of the great vessels. So think of it as a double-walled bag with a tight inner fit and a tough outer shell, right? The outer shell, which is the fibrous part, is tough, and the inner part, see it as a tight inner fit that encloses the heart directly. So from outside to inside, it has three distinct layers, but they are functionally grouped as what? Two main components. There are three distinct layers, but are functionally grouped as two main components. We have the fibrous pericardium and we have the what? We have the serous pericardium. The fibrous pericardium and the serous pericardium. So the serous pericardium now has two layers, a parietal and a visceral layer. We'll look at that shortly. So now the fibrous pericardium, which is the outer layer, is a tough, inelastic, conical shaped outer sac made up of dense connective tissue. Its base is firmly fused with the central tendon of the diaphragm. Inferiorly, its base is firmly fused to the central tendon of the diaphragm inferiorly. Its apex blends with the adventitia of the great vessels. The apex blends with the adventitia of the great vessels. We're talking about the aorta, the pulmonary trunk, and superior vena cava superiorly. Now, because it is inextensible, remember also it is inelastic, any rapid accumulation of fluid within it drastically raises the intrapericardial pressure because it's not elastic, it's not expansible. So there's going to be a drastic raise in intrapericardial pressure whenever there's a rapid accumulation of fluid within it. A concept you must memorize for cardiac tamponade. We'll look at that shortly. So we now have the serous pericardium, which is the inner two layers. We said we have structurally we have three layers, but functionally have two layers, the fibrous and the serous. Serous divided into two. So the serous layer is a delicate double layered serous membrane. It is double layered serous membrane that folds back on itself. It folds back on itself. It has two continuous parts. We have the parietal layer and we have the visceral layer. The parietal layer aligns the internal surface of the fibrous pericardium. Let's say this is our outside and this is our inside. This is where we have our heart. Let's say this is the heart, and this is where we have the pericardium. So this here you have is the fibrous pericardium. This here you have is the parietal layer of the serous pericardium, and this here you have is the visceral layer of the serous pericardium. So this fibrous layer of the serous pericardium is lining the inner aspect of the what? The fibrous pericardium. Do you understand? So it's fused to the fibrous sac and cannot be peeled away from it. They are fused. There's really no potential space between the two layers. Then the visceral layer, which is this, it's called the epicardium. This is the inner layer that adheres directly to the surface of the heart muscles and the coronary vessels. So there is adhesion of the inner layer of the serous pericardium and the heart directly, so they adhere to each other. So that means there is a space here in between the parietal layer of the serous pericardium and the visceral layer of the serous pericardium. So it is the outermost layer of the heart wall itself. That's why we call it the epicardium. It's the outermost layer of the heart wall itself. So now we have the pericardial cavity, which is a space between the parietal and the visceral layers of the pericardial cavity. It is a potential space. Please take note of this. It's a potential space that normally contains 20 to 50 mils of serous fluid. Now, what do we mean by potential space? You see, when you what am I going to use? Let's say your bed sheet and the bed itself. If you look at it from when you stand and look at it, you see that there's really no space unless you lie in your bed, right? There's really no space between the bed sheet and the bed itself. So that is a potential space. The two layers are in close contact to each other, but there's a possibility of a space. There's a possibility of a fluid creating a space, and there's a tiny amount of fluid in this space, about 20 to 50 mils of serous fluid. So that is why we call it a potential space. It has a potential of becoming a space. So the fluid acts as a frictionless lubricant, allowing the heart to beat and slide smoothly against the surrounding structures. The visceral layer is clinically crucial because it is the layer that becomes inflamed in acute pericarditis. It is the layer that becomes inflamed in acute pericarditis. So we have something we call the pericardial sinuses. Now, the pericardial sinuses are the serous pericardium is a complex because it wraps around the great vessels. Remember, we said it wraps around itself, right? It's a double layer that wraps around itself or folds back on itself, creating, so as it's folding back on itself, moving around the heart and its great vessels, it creates two recesses or two sinuses that are essential for cardiac surgery. It creates two recesses or two nice sinuses essential for cardiac surgery. We have the transverse sinus and we have the oblique sinus. So the transverse sinus is a horizontal passage located between the ascending aorta and the pulmonary trunk. Take note of this, the blood vessels that it is located between. It is located behind the ascending aorta and the pulmonary trunk, and anterior to the superior vena cava and the right pulmonary artery. Note that the superior vena cava carries deoxygenated blood, right? The right pulmonary artery also carries deoxygenated blood, while the right pulmonary artery, so if you look at this, you see that we have the ascending aorta and the pulmonary trunk in front of the transverse sinus. Then behind we have the superior vena cava and the pulmonary veins. Sorry, this is not the pulmonary artery, the pulmonary veins, please. That's not the pulmonary artery, the pulmonary veins. So between we have the arteries anteriorly. You should take this as a line. You have arteries anterior to the transverse sinus, and you have veins posterior to the transverse sinus. So this is not right pulmonary artery, it's the veins. So imagine lifting the aorta and the pulmonary trunk, which are anterior to it. Imagine lifting them forward. The space you see behind is what we call the transverse sinus. The space you see behind when you lift the aorta and the pulmonary trunk forward, the space you see behind them is the transverse sinus. So this is the pulmonary trunk and the aorta in front. So the clinical significance of the transverse sinus is that during open surgery, surgeons can pass a clamp or a finger through the sinus to encircle the aorta and the pulmonary trunk simultaneously to allow for controlled cross clamping or the initiation of cardiopulmonary bypass. So it's important during cardiac surgery. Now have the oblique sinus. The oblique sinus is a blind-ended recess located on the posterior surface of the left atrium. It is located on the posterior surface of the left atrium. If we go back to this structure, this is the oblique sinus. See it? It is between the left pulmonary veins and the right pulmonary veins. Between the left pulmonary veins and the right pulmonary veins. So it is in between veins, while the transverse sinus is between arteries and veins. So it is formed by the reflection of the serous pericardium around the 4 pulmonary veins and the superior and inferior vena cava. Think of it as a pocket behind the left atrium. Just imagine the left atrium. So think of the oblique sinus as a pocket behind the left atrium. It is clinically relevant because it prevents the heart from what? Excessively rotating within the sac, within the pericardium. It's a potential site for fluid collection in pericardial effusion, and surgeons must be aware of it to avoid inadvertently entering the pericardial cavity when operating on the esophagus and the descending aorta, because these structures lie directly posterior to the oblique sinus. So when performing surgeries on the esophagus and the descending aorta, surgeons need to be aware that there is a space here, the oblique sinus, to prevent inadvertently entering the pericardial cavity. So we have innervation of the pericardium, where we have the fibrous pericardium and the parietal layer of the serous pericardium. That is, the fibrous pericardium and the parietal layer of the serous pericardium are innervated by the phrenic nerve, which has a root value of C3, C4, and C5. It has somatic innervation, making these layers sensitive to pain, friction, and stretching. So the fibrous pericardium and the parietal layer of the serous pericardium are sensitive to pain, friction, and stretching because they have somatic innervation from phrenic nerve. Now, because the phrenic nerve originates from the cervical root C3 to C5, pericardial pain is classically referred to the supraclavicular region. You know, the supraclavicular nerve also has a root value of C3, C4, and C5. So whenever there is a pericardial pain, which is felt by the phrenic nerve takes this pain, the afferent fibers take this pain to the C3, C4, C5 segments of the spinal cord, and this pain is now wrongly interpreted as coming from the neck and the shoulder tops, because they are supplied by the supraclavicular nerves with the same root value C3 to C5. So the dermatome C3 and C4 are the pain is referred to this side. So this is why a patient with acute pericarditis often complains of a sharp pain that worsens while lying flat and radiates to the trapezius ridge around that region. So for the visceral layer, which we call the epicardium, it receives autonomic innervation, which is insensitive to pain, touch, or cutting. Insensitive to pain, touch, or cutting. It only responds to stretch or ischemia. Blood supply to the pericardium. The pericardium is highly vascularized. The highly vascularized structure, its arterial supply comes from multiple sources. The primary arteries are the pericardiophenic arteries, which runs alongside the phrenic nerve on the lateral surface of the pericardium. The pericardiophenic arteries, which are branches of the internal thoracic artery, the internal thoracic artery are blood vessels found side by side of the sternum. So pericardiophenic is a branch of that, and additionally it also receives smaller branches from the musculophrenic arteries, the descending thoracic aorta and the coronary arteries. Descending thoracic aorta and the coronary arteries. The musculophrenic artery is also a branch of the internal thoracic artery. For venous drainage, they are parallel to the arterial supply, draining into the azygous system of veins, the internal thoracic veins, and the coronary sinus for the visceral layer of the serous pericardium. So let's look at clinical correlates. We have cardiac tamponade. Cardiac tamponade results from a rapid accumulation. Basically, it is inability of the heart to expand, right? Because there is accumulation of fluid in the pericardial cavity. It could be fluid. This fluid could be blood, could be anything. So they accumulate in the pericardial cavity, often as a result of trauma, aortic dissection, or a post-infarction rupture. Now, because the fibrous pericardium, we said, is inelastic and cannot expand, even about just 100 to 200 mils of fluid in this space can severely compress all the 4 chambers of the heart. So the clinical triad of cardiac tamponade is called the Beck's triad, where you have hypotension, muffled heart sounds, and elevated jugular venous pressure. So this is the heart with its sacs. See the blood inside the space. So there is compression on the heart. We also have acute pericarditis. Pericarditis, from the name, it is a medicine. It's inflammation. So we're talking about inflammation of the pericardial layers. Now, the inflamed parietal layer of the pericardium rubs against the visceral layer, excuse me, producing a classic pericardial friction rub. There's inflammation of the pericardium, so because of this inflammation, the layers rub on each other, producing a classic friction rub, having pain. We also have pericardiocentesis. Pericardiocentesis is a procedure in which pericardial fluid in the pericardial cavity is drained. So when performing a pericardiocentesis to drain pericardial effusion, the clinician must avoid puncturing the lungs, the internal thoracic artery, or the heart itself. So whoever is performing this procedure has to have a good knowledge of the anatomy as well as the surface anatomy of the thorax. So the standard subxiphoid approach is the safest and most tested approach, where one is approaching the heart from this direction. It's called the subxiphoid. We have the xiphoid process of the sternum to the subxiphoid approach. So the needle is inserted at the left infrasternal angle, just below the xiphoid process. It is directed superiorly, posteriorly, and to the left, aiming towards the tip of the left scapula. In this direction. Put the needle as if you're aiming towards that direction. Now the needle traverses the skin, subcutaneous fat, and diaphragm, as well as other structures, then enters the pericardial sac at its inferiormost aspect, just above the central tendon of the diaphragm. Now, warning: the phrenic nerve runs lateral to the pericardium. So, as well as the internal thoracic artery, like I said, internal thoracic arteries are found on the side by side to the sternum. So they run parasternally. So the phrenic nerve runs lateral to the pericardium, as well as the internal thoracic arteries that run parallel to the sternum. So this subxiphoid route avoids these structures. That's the importance of this route for pericardiocentesis. It avoids the phrenic nerve as well as the internal thoracic arteries. However, clinicians must be constantly aware of the right ventricle lying immediately anterior within the sac. So the needle must not go too deep into the right ventricle. So this is fluid in the pericardial cavity, and this is using the needle to collect this fluid, pericardiocentesis, using the subxiphoid side, the angle at around 45 angles of the needle is placed in 45 degrees. So thanks for watching. Don't forget to like, share, and subscribe to Alacrity Explains for more videos. Please share these videos. Comment if you have any comments. Please drop a comment. Thank you for watching.